I'd like to thank everybody to the July MTAC trauma lecture. This month, we're pleased to welcome Dr. Jordan Grier from OrthoCarolina. He's going to be speaking on the management of hand trauma. Dr. Grier is a fellowship-trained hand and upper extremity surgeon at OrthoCarolina, as I mentioned, and he completed his undergraduate degree at The Ohio State University. Before he went to med school at Duke University in Durham, and then he also completed his residency in orthopedics there as well. Then he came down to Charlotte and completed additional subspecialty training and got his fellowship in hand and upper extremity surgery, peripheral nerve surgery, brachial plexus surgery, and microsurgery at the OrthoCarolina Hand Center. So we have a foremost expert here to share some of his knowledge with us. And so I welcome Dr. Grier.
Awesome. Thanks for the very nice introduction, Scott, and I appreciate the group for joining this afternoon to hopefully provide a little bit more clarity about some of the things that we see on the hand and upper extremity side as common injuries that are presenting to the ERs and to our trauma centers that certainly can be a source of a little bit of challenge in terms of evaluation and management. And hopefully this will provide a little bit more clarity about the framework that we use on our side of the table when we look at these hand and upper extremity injuries that are presenting to the trauma centers and how we try to triage or compartmentalize what needs to be seen acutely, what maybe need to be seen acutely, and what can likely be packed up and sent out. So hopefully at the end of this talk, you'll have a better sense of the framework that we use to go through these injury patterns and how we decide who needs seen when. So our goals for this talk are to identify the key features and evaluation of common hand injuries presenting to the ED. So this is not going to be a comprehensive evaluation of all things hand that you'll see, but hopefully we will hit the high points, hit the topics that are the source of greatest stress and consternation as to whether or not we need called or not. Differentiate injuries that require urgent hand surgery consultation from those that are appropriate for initial ED management and triage, and close outpatient follow-up with a provider in our specialty. And then hopefully be able to apply this evidence to inform principles of initial management, wound care, antibiotics when indicated, tetanus prophylaxis, immobilization, imaging, and then ultimately disposition planning. Let's see here. Here we go. So in terms of ED hand consultations, these are extremely common in both just freestanding EDs, any ER setting, as well as in the trauma center. And even small injuries on the surface can have major functional consequences. So we see things all the time that are overlooked just due to the size of the anatomic area that's injured, size of the wound, the bone that's broken, in terms of it being disproportionately sort of pushed aside as perhaps not as urgent as what the actual injury pattern may be. We see a lot of gunshot wounds, open fractures, tendon injuries, fingertip trauma that can create uncertainty about whether or not this needs any sort of additional management in the ER. Can this person be otherwise temporized and sent out? And our goal is to improve consistency in the early evaluation, treatment, and then ultimately outpatient disposition for most of these patients. So my mental framework when I think about how do I evaluate these injuries, how do I go about thinking about how to triage and manage the hand injury patient in the ER, a lot of it starts with just examination and documentation. And as straightforward as it sounds, we see that be one of the major pitfalls in these patient encounters quite frequently, sometimes due to just an unfamiliarity with the anatomy of this area. It's a very specialized group of bony and soft tissue structures that, if you haven't been exposed to some of these types of injuries and pathologies before, may just not be as familiar to you as things that you see all the time in the ER. And that can lead to some shortcomings in terms of both the physical examination performed and documentation, not because of lack of effort or knowledge. It's just something you don't see and do all the time. So really being diligent in examining the patient closely, and we'll talk a little bit about the things we look at, and then just documenting what you see. People get very caught up in terms of what specific things need to be included or special tests or buzzwords we're looking for. I always tell people that the best thing you can do is to paint the most accurate picture of the patient and of the hand you see in front of you, because that helps us understand a little bit better as to what that looked like on initial presentation, because oftentimes the patient that we may see in the office after some intervention has been done is a bit different than what this hand or what this limb looked like on initial presentation. So just tell us what you see in the documentation. Appropriate imaging is critical. So that includes, imaging of that entire part of the extremity. We'll see oftentimes, dedicated finger films for things that may have involvement more proximally in the hand, or not getting additional imaging, or things that include the entirety of the injured bone. So for, distal radius for fractures, for example, including an image of the proximal forearm or the entire forearm axis to make sure that we have a good global assessment of what that bony injury pattern looks like throughout the entire osteology of that bone. Thinking about how we can temporize and manage wounds, irrigating them thoroughly, anesthetizing the area as needed to facilitate wound closure and dressing, and then appropriate splint and dressing application that's going to provide support and coverage for the area while not being unnecessarily prohibitive to motion that should be allowed for the patient during their early phase of recovery. And then the decision point of whether or not this is something that needs consultation. Do you need to get one of us involved, whether it just be for advice on how to temporize this, or whether it be the need for true inpatient or bedside consultation, or just the need for a close outpatient follow-up. And the biggest thing is avoiding missing the injuries that truly change patient outcomes. So the ones that really need to be managed in the ER and not just temporized, trying to do the best we can to not miss those. And I think that for the most part, people do an incredible job of doing that. I think it's probably the other end of the spectrum where there are plenty of things that, are the sought consultation on an inpatient setting that probably from a patient standpoint and an overall healthcare resource standpoint may be better served with temporization and getting them to close out patient follow-up where we can truly make more decisions about how to definitively manage these patients. My sort of big picture is 60-second hand trauma exam. So if you take nothing else away in terms of the other special tests or other unique pathologies that we would be looking at and things that we think about in the hand surgery, this is what I look at. And this is what you could very easily document in your note. Document what the skin looks like. Are there wounds? If so, where are they? How long are they? Is there any contamination? Are there exposed structures within the wound, whether that be bone, tendon, nerve, artery? Is there any tissue loss? So are there wounds that have significant amounts of tissue loss that are going to result in the inability to close the wound primarily and will truly have a wound that will need to be managed with something other than primary closure in the future? The resting posture and any visible deformity of the digit, sometimes just simply looking at the hand and wrist, describing what it looks like at rest, where is there a visible deformity about the hand or wrist, can help to paint a picture for us as to what we need to be keying into. A vascular examination that's well documented, so the color and temperature of the digit, the capillary refill, so how quickly or how slowly that refills, and then any relevant peripheral pulses. And one thing that I'll tell folks is that the pulse oximeter is your friend in evaluating many of these vascular injuries. We may touch on this in a bit as well, but oftentimes the first thing we'll ask folks to do when we get phone calls about digit trauma, specifically fingers where there's concern about dysvascularity, is to put a pulse oximeter on the distal aspect of the digit and look for a waveform. Compare that to adjacent unaffected digits, either of the same hand or a contralateral hand. It gives us a good sense of what the actual perfusion of that digit is. And if we can pick up a waveform and they have a tissue perfusion of 96 or more percent, the likelihood that that digit has had a significant vascular injury that can result in compromise is far lower than one where you really can't pick up a waveform or you have a weak waveform and a 60%. That's a digit that may be at risk. So beyond some of those subjective documentation in terms of the color, some objective data about the capillary refill and pulses, that pulse oximeter can be a huge benefit to us in terms of understanding, is this digit receiving enough perfusion or is it critically dysvascular that it may need intervention? Motor examination, documenting the flexion and extension of each the wrist and the key digits in the hand, and then key tendon function, particularly for laceration injuries. Do they have function of their digital flexor tendons, extensor tendons? Just tell us what joints they can move and what they can't move if you're not familiar with the function of each of those respective tendons. It tells us enough if you can at least tell us what parts of the finger move and don't move, and we can usually kind of key in based on what you have documented there and where the wounds are as to what may be injured. Sensation-wise, the major peripheral distributions that we worry about in the hand, the median, ulnar, and radial nerve distributions. We'll talk a little bit about my way of going about evaluating that. And then any bony or alignment issues. Is there any sort of objective bony tenderness, instability, or rotational malalignment of the wrist or digits that are involved? So if you can at least go through those things, synthesize those kind of quick, easy steps, this will give you the bulk of what we would want to see or hear about in a consultation phone call. This gives a ton of information without any special tests, without any really advanced knowledge beyond the basic examination of the hand and wrist. Other key things that are pitfalls that we see quite often are rings or other pieces of jewelry that are left on in injured digits. We'll see trauma radiographs all the time where there are still rings or bracelets or other things in place. If the patients cannot get them off, there are a few different tricks we can use to try to get those off. Things like, either a lubricant or Windex even work quite well on trying to provide at least enough decrease in friction to get those pieces of jewelry off. And if needed, they need to be cut off, because we see a number of times per year where patients have one of those things left on. Someone tells someone, hey, you should take that ring off, but it's never really followed through or called back to make sure that that's been done, and people come in and they have an ischemic digit as a result of a piece of jewelry that could have easily been removed previously. Making sure that you document the examination that you're getting of the involved area before performing any sort of anesthetic block to that respective digit or part of the limb. We'll get phone calls quite frequently where patient comes in, they have a laceration or they have some sort of injury. They're provided with a block, a digital nerve block, or some sort of other local anesthetic, and it really clouds the diagnostic ability both of that practitioner who performed the initial block, or if they require consultation, we come in and the person is anesthetized. It really provides for a lack of clear understanding as to what may be injured, because now they've been anesthetized and you can't get a good exam. And always thinking about the fact that small wounds can hide much deeper tendon, nerve, joint, or bony injuries. So don't be fooled by the size of some of these wounds. I tell patients all the time that some of these smallest wounds that we see, 1 centimeter or less, that result in laceration of things like flexor tendons or other critical structures, can pose significant limitations and risk to that digit or that limb. So don't be fooled by the size of the wound, and make sure that you're critical of any and all wounds that patients are presenting with, no matter how small or trivial you think it may be. It may be hiding something more critical below the surface. From a sensation standpoint, I think the easiest way to document this is to just have a reproducible area where you're going to check the sensation for each of these 3 critical domains. So for median nerve sensation, I typically will evaluate the palmar aspects of either the index or middle fingers over the middle or distal phalanges. That usually is going to give you a very clear understanding as to what their sensation is in the median nerve proper distribution. For radial nerve sensation, I prefer the dorsal radial aspect of the hand. So right over the first web space between the thumb and index finger, very well conserved that's going to be covered by the superficial branch of the radial nerve without much overlap in that particular anatomic location. And then ulnar nerve sensation, really anywhere about the small finger ray. The palmar aspect is provided by the proper branches from the ulnar nerve that are traveling along the palmar aspect of the wrist and through the hand. The dorsal aspect being provided by the dorsal sensory branch of the ulnar nerve, which exits that nerve a little bit proximal to the wrist. But I think if you're evaluating the small finger distal to the PIP joint, that's going to give you a very clear understanding as to whether or not there is or is not intact ulnar sensation. So the best thing you can do is to document each of those major areas, and if there is a laceration to any of the actual digits, then evaluating and documenting if there is a side, either radially or ulnarly, of that respective digit that they are insensate. So the best thing you can do is to just over explain what they can feel, what they can't feel. It helps to give us a very clear understanding, and doing so before providing a digital nerve block. That I know that patients come in and they have discomfort, but once a nerve block has been performed, either at the wrist level or digit level, it really obscures our diagnostic ability. So doing the best you can to document those things carefully before providing anything that would confound that examination is really critical. In terms of motor examination, my preference for documenting the critical motor nerve function distally. For the radial nerve, I ask them to give me a thumbs up. That provides you with a gross examination of the extensor pollicis longus tendon function. If they can extend the IP joint of the thumb, that tells you that the EPL tendon is intact and they should have intact radial nerve function. For the median nerve, and specifically the AIN branch of the median nerve, I usually ask them to make that AOK sign that you see there on the far left. That requires them to perform thumb IP joint flexion, which is performed by the FPL, and DIP joint flexion of the index finger performed by the FDP of the index, both of which are innervated by the AIN. So that gives you a very clear examination, objective determination about their AIN function. And then ulnar function, usually we're testing the interossei, asking patients to cross their fingers fingers, or abduct or spread the digits out against resistance. Would just make sure to do that very cautiously. Sometimes patients can fool you, especially with the abduction or separation of the digits. They can do that through their finger extensors as well. And that's where I feel that the crossing the fingers or adducting those digits together really is probably a cleaner test than the abduction, because they can sometimes cheat and fool you with their finger extensors. But crossing of the fingers or adduction towards the midline, towards the midfinger, is a really good test to make sure that their interossei are intact. So what must be documented? Things that we definitely want to see in a note from a consultant, or when we're looking at outpatient notes from an ER or urgent care consultation. The mechanism of injury clearly described, whether or not this was an open or closed injury. Is there any sort of contamination, any disruption of the soft tissue envelope that was not amenable to a primary repair? Tendon function in the critical areas that we would be interested in distal to the site of injury. Neurovascular status, like we talked about, so the motor and sensory function for those key peripheral nerves. And again, doesn't take much to test those 3 motor functions, 3 sensory domains that we would want to see, and then the vascular component of it, not just the capillary refill, but then also, if needed, pulse oximetry on an involved digit if there is one specific digit you're concerned about. Radiographic findings, so making sure that you are also looking at the radiographs, as I know we've all been harped on that, the radiologists have their own framework via which they interpret radiographs that go along with their training and how it is meant for the radiographer or radiologist, to interpret the image. But you, as the clinician that's seeing the patient, also have a different lens through which you're going to interpret their radiographs and things that about their limb, their arm, their hand that the radiologist may not be aware of. So you have a different lens through which you can look at some of the critical aspects of their radiographs and at least provide some commentary. So not just copying and pasting the radiologist read, but also providing, if possible, some commentary on your own as to things that you were concerned about in getting the radiographs in the first place and how that relates to what you see on the radiographs performed. If there is any reduction of a fracture that's performed, so a displaced fracture of the wrist or hand that you deem or you're instructed to attempt to close reduction of, documenting the status of not only what radiographically that bone looks like, but also their neurovascular and tendon status after the closed reduction is performed, so that we understand if there was some sort of deficit pre and or post reduction and how that may have changed, and then their disposition and follow-up plan. So it's nice at the bottom of the note, we scroll down and we see whether or not there was a consultation or at least a phone call discussion with a provider within that domain, and then what the outpatient follow-up plan will be for that patient. One thing that I think is very helpful that has been put together by the American Society for Surgery of the Hand and the American College of Emergency Physicians is this hand surgery consultation and transfer guidelines. So this goes over some of the injuries that we'll talk a little bit about here over the course of the rest of the talk, but also is a very handy tool that you can always print and put up in the pod. This QR code, if you scan it, should go directly to that guideline sheet. And I think it's pretty well vetted. And while it's pretty broad, it does provide at least some form of framework as to, what is something that likely doesn't require hand surgery consultation during the initial encounter, what may require our involvement, and those things we're never upset about hearing about. Better to know about it and be able to help provide some guidance as to what that patient needs. And then the things that may need a more immediate hand surgery consultation and or transfer if indicated for more acute injuries that may require surgery within the initial evaluation of that patient. So this is a really handy tool. I'll leave it up here for just a second if you want to just take a screenshot of it, or if you scan that QR code on the right, hopefully it's live and should go directly to this PDF. If it's not, just drop a message in the chat and I can send a link to it to y'all directly, but hopefully either with a screenshot of it or the QR code, you'll be able to get a copy of this. I think it's really helpful. It provides a good framework as to how to approach, what should I call about, what I may not need to necessarily call about. Okay, so thinking about this, who needs urgent hand evaluation? So things that I think about as being injuries that require our involvement right away are things that involve true vascular compromise to a limb or digit, open fractures that have significant contamination, tissue loss, or some sort of associated neurovascular injury, fight bites, which we'll talk about in a little while, flexor tenosynovitis, so another infectious issue that typically requires inpatient surgical management, High pressure injection injuries we'll talk a bit about as well. Complex gunshot wounds, amputations or near amputations, particularly if they're more proximal in the limb, and then irreducible dislocations or unstable fracture dislocations that we don't want to send out without some degree of stability, whether that be with a different splinting modality or if they need to go to the operating room to have some sort of provisional fixation or reduction performed. Things that are often appropriate for close outpatient follow-up. Most stable closed fractures, even if they're things that are going to require surgery, typically we aren't going to do that during their index encounter. That many times those patients can be temporized, sent out, and then evaluated by a hand and upper extremity or traumatologist that can take care of that injury. Simple reduced dislocations. Most fingertip and tuft injuries do not require inpatient consultation. Low velocity gunshot wounds that have stable fractures and stable neurovascular exams, we sort of treat those like closed fracture equivalents, so different than the high powered rifle, high energy injury. Most low velocity gunshot wounds with stable fractures, neurovascular status is stable, and tissue that's amenable to either dressing application or a loose primary closure, most of those can be sent out. And I know that in particular can be a huge source of stress, but I'll tell you that the majority of those folks can be temporized and sent home. Selected low complexity open fractures. So we'll talk a little bit about open fracture management because it's a little bit different for us in the upper extremity world than most of our lower extremity colleagues. And then suspected tendon lacerations that don't have any contamination or a neurovascular injury that's posing immediate threat to the digit. So those can also be splinted and sent out. So talking a little bit about each of these specific injury patterns, gunshot wounds and associated fractures. For these, what changes our management is a lot of times the status of the soft tissues and their neurovascular exam. So making sure you have a well-documented neurovascular exam. This is when, again, the pulse oximeter can be your friend. You get someone who comes in with the hand that looks like it does on the right there, very easy to get overwhelmed, even for us when we see some of these. So going back to the basic principles, evaluating the color and turgor of those digits, putting a pulse oximeter on them if you need to, and you'll be surprised how many of them still have collateral perfusion that's keeping that limb alive and provides us a little bit more time in terms of planning and decision making as to what the most appropriate disposition is for that patient. Evaluate for the presence or absence of any associated fractures, tendon, nerve, or vascular injuries, violation or traumatic arthrotomies of any of the joints, what their soft tissue status is there tissue loss and contamination, and some of the other basic medical management items in terms of confirming their tetanus status immunization and updating if indicated. Antibiotics based on the wound and fracture pattern. I have a little table that we'll go over here in a second. And then appropriate dressing application. So copious irrigation of those wounds with sterile saline or sterile ringers, a nonstick dressing such as Xeroform or Adaptic over the open wounds. So please just don't put dry 4x4 gauze over there. All the interstices will get totally stuck into the bleeding areas, either in the soft tissues or over the bone, and will be really uncomfortable for the patient and really challenging for us to get off. And then provisional splinting and determination of disposition. Consultation is typically indicated if there is any sign of limb or digital ischemia. Again, pulse ox on the involved digit goes a really long way. Any associated unstable fracture patterns that you think are not amenable to just being temporized and sent home. If there's substantial soft tissue loss, that's really not going to be amenable to just a simple dressing. And sometimes that is a little bit of a conversation with the treating surgeon as to what that may ultimately entail and whether or not they think it would still be appropriate from their standpoint and they would be willing to accept that patient in follow-up directly for management of any of the soft tissue component of their injury without any inpatient or ED soft tissue coverage procedures performed. If there's major tissue loss, oftentimes that's going to require a consultation to determine whether or not that person needs to stay for soft tissue coverage. Tendon or nerve injury, if you're concerned that it may be something that is going to need more urgent management, many of those can still be managed on an outpatient basis, but certainly for a large critical peripheral nerves, median nerve, ulnar nerve, radial nerve, more proximally in the forearm or higher, oftentimes we should know about, and then intra-articular joint involvement. And even when some of these criteria are met, a lot of these patients are still going to be amenable to temporization and close outpatient follow-up. So as with anything, communication is key with these, that we're available. We want to be made aware of these patients so we can help with their disposition, make sure they get everything they need, and that if they can be discharged, they are discharged home. If they need to be kept for further management before they're safe for discharge, we want to make sure we can help guide through that process. But not every one of these patients is going to require in-person consultation. That sometimes it is a matter of being able to do the best we can to temporize the injury and then get them close clinical follow-up with one of us on the hand and upper extremity side on the outpatient side. In terms of fracture management and grading how we deal with the antibiotic considerations, this is a nice table that goes over how I think about each of the Castillo-Anderson grading scales for open fracture management and what sort of antibiotic prophylaxis they need. So we see a lot of, quote, poke hole open fractures, and sometimes this is overused. We'll see a number that are, described as poke hole, and really it's a centimeter and a half. So that's different in a hand than it is in a femur or something, for example. But these very small wounds with minimal soft tissue contamination or visible soft tissue injury, oftentimes we can treat either as an otherwise relatively closed injury or treated like a grade 1 with just a simple antibiotic, whether this be Ancef or if penallergic, some alternatives you see there. And most of the time, those people are very amenable to discharge home and outpatient management for their open fracture. Same goes for many grade 1 injuries, especially if they're amenable to primary closure. You have the antibiotic options listed there to the right-hand side. And similarly, as we get through grades 2 in the different subclassifications of grade 3. So this is another one that if you wanted to take a picture of a screenshot, print it out, put it in the pot, I think that this has a good overview of the way we think about at least how each of these different open fractures may differ in terms of what they may need for antibiotic prophylaxis and how we would think about making sure you cover any unique contamination situations like you see in the bottom, for example, with farm or soil contamination, which we'll see quite regularly in this part of the state, especially if there are transfers from more rural centers, and then some of the other considerations for water exposure, whether it be fresh or salt. So this is another table that if you're able to take a picture of on your phone, screenshot, save it so you have it for your reference. And there are a number of different iterations out there, but this is in general how I approach thinking about the antibiotic management for the open fractures. Now, in the hand, it's a bit unique in that, the vascularity and perfusion potential, the ability for these fractures to heal, fortunately for us, is much greater than a lot of what we see in our lower extremity fractures. So our colleagues that deal with the femur and tibia fractures have a lot harder time with many of these than we do. We're fortunate that we have excellent perfusion in the upper limb, and oftentimes we're able to get primary soft tissue coverage or easy local coverage options to get these things taken care of. So this classification scheme that you see on the right side was published by Ossiphilius and Hand Clinics, and I think is a really nice way to think about how we can triage and stratify what patients are going to be amenable to initial just soft tissue coverage and closure in the ER with discharge home versus who needs to stay. So if we look at the table, they have types 1, 2, and 3 being those that involve the phalanges, metacarpals, and carpus respectively. Any of those fractures without a modifier typically does not require any sort of emergent surgical treatment, can be managed with antibiotics and a washout in the ER alone, followed by standard fracture management, which in many cases can be non-operative treatment. If it's a metacarpal fracture that even if open is primarily coverable without contamination, we typically treat them with antibiotics and can treat them in a closed fashion. Once you get down to the modifiers, now you have to think a little bit more critically about whether or not there's something that patient will need. So for the A modifiers, where you can't cover them primarily, many of those will still need antibiotics in the ER and a washout, and then we'll typically think about semi-elective soft tissue coverage and standard fracture management. So that's still a patient that may be amenable to discharge home. Many of those folks we don't keep and try to cover in a main hospital OR setting just because of availability and acuity. That's something we can typically treat on an outpatient basis in a different setting and get to in a timely manner without them having to stay. The B-type fractures where there is frank contamination, now you're getting into the realm where we typically will keep those patients for a more formal operative debridement and then early versus delayed fracture management based on the status of both the bone and soft tissue following debridement. And then modifier C, where you have some sort of vascular compromise, those patients are going to stay because they likely need a revascularization, and then we can manage their fractures concomitantly at the time of surgery. So a little bit different paradigm than what we see in lower extremity fractures, where they're a bit more dogmatic about most of those folks staying in the upper extremity. And I would expand this even to these kind of poke hole open or type 1 open distal radius fractures. Many of these can now be debrided, temporized in the ER, provisionally splinted, and sent for outpatient follow-up. It's really those ones that have frank contamination or dysvascularity that are going to require some sort of more urgent operative intervention. Moving on to looking at fingertip injuries, which are probably some of the most common things that you're going to encounter in these ER presentations. Thinking about the anatomy of the fingertip, it's more complex than we likely give it credit for. The areas that are important to understand anatomically and be able to describe in your note are as listed here. So the eponychium is that skin, the tissue that's just dorsal and proximal to the nail plate. So that skin, if you look down, that's just proximal to where the nail plate exits at the tip of the digit is the eponychial fold. And below that, you'll have part of the matrix that helps to create the nail. So the germinal matrix is underneath and almost in a C shape around that portion of the eponychium. And that's going to be responsible for the majority of your nail growth. The peronychium or the peronychial folds are those lateral folds radially and ulnarly about the nail complex, a common site of infection where people will get peronychial infections, where you'll get bacterial proliferation in that small crevice and interface between the nail plate and the peronychial folds, and they'll come in with a very red, swollen, inflamed peronychial tissue fold. The hyponychium is a small plug of keratinaceous material that's below the distal edge of the nail, keeps that nail down against the skin. Many of you have probably experienced some dissociation of that from the nail plate itself. When the digit is forced in a position where the nail plate is contacted, it elevates the nail plate. You've likely disrupted a little bit of that hyponychium, which can be uncomfortable, but typically doesn't result in much disability. The lunula, or the small area of lucency that you see dorsally over the nail plate, if you look just beyond the eponychial fold, demarcates for us at least where we think about the barrier between the sterile and germinal matrices. So the sterile matrix is the part that sits below the nail plate, the hard part that you see that keeps the nail adherent. And again, the germinal matrix, like I mentioned, primarily being below and around the eponychium that helps to generate the majority of the nail. The pulp itself serves a very important purpose as well. It has thick epidermal and dermal tissue there. It is hairless glabrous skin, has abundant endocrine sweat glands, our small cutaneous folds that create our unique fingerprint, and has abundant sensory receptors. So that's what makes so many of these injuries complex, is that septation between those subcutaneous fatty tissues below the dermal layer and then those sensory receptors being so prone to injury when you have trauma to the fingertip. Our goals with fingertip injuries are to achieve a painless fingertip that's durable, sensate, and has skin that's available and amenable for pinch activities. We want to maintain as much length as we can. When possible, preserve the nail and avoid deformity to it, minimize pain, and optimize the patient's healing time. So evaluation-wise, these folks do need x-rays. So even if it looks like it's just a soft tissue pulp avulsion, there are certainly times where fractures can hide below the surface there, even if it doesn't sound like a mechanism which would have created one. So I would recommend x-rays for all of the fingertip injuries. We want to evaluate and document the amount of pulp that's been lost, any injury to the nail bed. And again, even if you're not super familiar with those different parts of the nail bed, just tell us whether or not the hard part, the nail plate, is on or off, and if you can see any laceration through the tissue that's below the nail plate. That in and of itself provides plenty of information, and anything beyond that is not necessarily within the scope of what needs to be done in the ER. And then whether or not there's any associated distal phalanx fracture. Most of those can be treated non-operatively, but it is helpful to know from our standpoint whether or not there's a fracture there as well. And the key questions to be asking yourself when you look at these folks is this something that can heal with dressing, splinting, and close follow-up? Or is there enough tissue loss, exposed bone, or fracture instability that they may need something else in the ER before they're discharged? When we think about how to manage these, there's the concept of the reconstructive ladder. So working our way from the most simple forms of treatment for the soft tissue injury all the way up to things that are more complex like free flaps, which we won't talk about in this talk. But this is kind of how we think about how to manage these. The most straightforward way to do so, the least invasive, the lowest rung on the ladder, is healing by secondary intention. And this does quite well for tip defects that have less than about 1.5 centimeters squared without much in the way of exposed bone. Sometimes that does mean using a rongeur and debriding back a couple millimeters of bone to make sure that now you don't have exposed bone within the wound. But if that is achievable, many of these heal well via secondary intention. That's someone who we're going to apply a nonstick dressing to and get to us in the office over the course of the next several days so we can get them started on bandage changes. Many times that's going to be done with either a wet to dry moistened gauze in an antiseptic solution or some sort of other nonstick, either adaptic or petroleum gauze dressing, and a small splint for the fingertip to protect it. So these are folks that oftentimes do quite well with having their wound gently irrigated and debrided in the ER, having a nonstick dressing applied, small finger splint that just incorporates the DIP joint unless there are other fractures, and then referral to us. And that's a key point that we see a lot of folks that go out and splints that incorporate the entire digit. That's not necessary for a fingertip injury and can result in disability of those other joints. So really just protecting the DIP joint for these is sufficient. These are just some case examples of ones you look at in the ER. You're like, oh gosh, how is this possibly going to heal? Is it going to do okay? You can see on the top left the initial injury images. Top right are after initial closure, kind of using what we have, almost like a fillet flap. Use what you have to cover what's exposed. And then you can see that progression from 2 weeks and then ultimately at 6 weeks. And it's hard to convince patients of this when they're in the ER. They feel like they want something done. We have the same conversation when they come to the office. They really want, quote unquote, something done to fix this. And it's hard to explain to them, but many of them, once they get through it, realize that your body has an amazing ability to heal these fingertip injuries, and most of them do quite well with just healing via secondary intention alone, and can have very durable, sensate, viable tissue at the tips of these digits, even with initial complex trauma. We look at the next level of the ladder. Now we're looking at whether or not we need to do something like a revision amputation and primary closure. Oftentimes, these are injuries that have a couple millimeters of exposed bone and less than 5 millimeters of sterile matrix remaining. In those cases, we'll debride that excess bone to allow for a primary closure. You can see in that bottom right picture, now you've got the bone debrided far enough back below the tissue surface that you should be able to obtain a primary closure. What you want to avoid is shortening the bone and shortening that distal phalangeal segment proximal to the extensor and flexor tendon insertions. So if you are having to get shorter and shorter, and it's getting to a point where now you're getting into the areas where the terminal extensor tendon and FDP tendon insert on the distal phalanx, that no longer becomes a viable distal digit. At that point, that patient is going to be better served with having a disarticulation through the DIP joint and then using the healthy skin in that area to close over the disarticulated portion of the digit. So just have to be mindful of, as you get more and more proximal, if they can no longer flex and extend the tip of the digit. And I ask them to do it as I go through the process of this, because we do most of these awake. If you're getting to the point where you're now in an area where they no longer have the ability to perform those functions, typically a formal disarticulation through the DIP joint can be performed with primary closure. And that again can be done in an ER setting. Does not have to go to the OR for that to be done. Follow up with us in clinic in 5 to 7 days for a wound check and counseling on expectations for long-term healing. As we get into the more complex finger injuries, these are the things that cause a ton of stress when you get calls about parts that are in bags, parts that are no longer on the person. These are the things that cause a lot of stress. So, indications for replantation have really become quite narrow. And in 2026, I would tell you that the vast majority of patients with digit loss, particularly isolated digit loss, are certainly not good candidates for replantation. That the indications for this have become so narrow because the outcomes are, quite honestly, suboptimal relative to what we would hope for these patients. So the things we're thinking about for these folks are the patient characteristics, their mechanism of injury, the level of amputation of the part, and then the status of the amputated part. So thinking about each of those from a patient characteristic standpoint, age plays a key role. So young patients, particularly teens and younger adults, are going to do much better with this than patients who are later in life, just because of their physiology, that they have a better capacity to heal than our older adults. Medical comorbidities play a critical role in this. So patients who are, diabetic, who have other significant peripheral vascular disease that may limit the inflow that we can achieve in a replanted part. And then also thinking about social history-wise, if they are smokers, it's not an absolute contraindication, but it's a pretty heavy relative contraindication for most of us. And for many of us, for isolated digits, we're oftentimes not going to offer replantation to patients who are smokers. Occupation-wise, what do they do for work? Is it going to be beneficial for them to have some sort of attempted replantation because of some specific vocational or avocational need they have? Or is it actually more desirable, as much as they don't want to have digit loss, to undergo revision amputation, primary closure, have that healed in a couple weeks, and be able to go back to work? Psychological problems play a big role in this. So whether or not, number one, they have capacity to make the decision and understand the complexity of what a replantation entails. These are things that you're going to be in surgery for potentially many hours for major limb or multi-digits, sometimes 8, 12 hours, long hospital admissions, including intensive care unit stays followed by floor stays. So they may be there for a week. So whether or not they really have the mental capacity or the facility to be able to make an informed decision about what that means for them and tolerate all of the post-op care that goes goes with it. And then their expectations and ability to participate in rehab. So if it's someone who has very limited access to the rehabilitation that they'll need for after surgery, in many cases, we're not doing them a service by putting on this replanted part, that they're going to have a digit that's going to be stiff, not viable, not usable for them, and may just be a source of pain. So sometimes that can be a very tough conversations with patients because they obviously think, oh, if there's an operation where you can put it back on, why wouldn't you do that? But the reality is that a lot of these do not function as well as what we would hope for. And as much as it can be done, it's a very elegant operation. They just quite frankly do not have as good an outcome as many of us would hope for. Some of this will also be based on the level at which the digit's amputated. So the more proximal the part, the more likely we are to put it back on. So we'll see at least 1 to 2 per year major limb replantation requests. So through the humerus, through elbow, through forearm. A number that are through hand or partial hand amputation, then multi-digit thumb, are all indications for us to at least highly consider, if not attempt, replantation. In some cases, it's just deemed intraoperatively that it's not going to be achievable or successful, but these are situations where we're going to give much stronger consideration to a replantation attempt. Anything in a child is also typically an indication. So for many adults, a single digit distal to the FDS we may consider and talk about, although as I mentioned, they typically don't do well. Children, it's a little different story. For many of them, we will still attempt replantation for single digits, and certainly the thumb in a child, we will almost always go to efforts to save. So those are things from just an anatomy standpoint that we would be thinking about as we approach these types of replantation candidates. Mechanism of injury plays a huge role in whether or not patients are a candidate. So clean, sharp lacerations typically are going to be patterns that are going to be more amenable to replantation attempts because the vessels in particular are still going to be of high enough quality that microvascular anastomoses can be achievable. Limited crush, limited contamination. As we get into higher degrees of either of those, now we worry, number one, about risk of infection, and particularly in crush and avulsion injuries. The damage done to the vessel is really quite extensive and extends beyond what you would expect the zone of injury to be, that there's injuries to the intimal tissue of those small vessels. And if we're already looking at anastomoses that are going to be performed with 8, 9, 10, 11 suture, if you now have injuries to the intimal wall, it makes it very hard to achieve a patent anastomosis and provide a viable digit for the patient. When we think about ischemia time, this also plays a critical role. So for digits, because there's really no muscle in the digit, you can tolerate a lot longer ischemia time. So warm ischemia, not on ice for 12 hours, and on ice for up to 24 hours, or in some instances longer. There are centers across the world where they're actually doing this in a somewhat subacute or a semi-elective fashion, where they have a dedicated trauma room or a hand trauma space where replantations that come in overnight are booked as a sort of first start case for the following morning rather than being a 2 a.m. case. And the benefit there is that then we have a team in the room that's familiar with hand and microvascular surgery rather than calling upon our colleagues who may not see or do any microsurgery or deal with some of the instrumentation and nuances that go into these procedures. So that prolonged cold ischemia time can really be used to our benefit in deciding when is the right time to trial this. In the arm, or more proximally in the limb, now you have to deal with the issues related to the muscle ischemia and the metabolic byproducts of reperfusing those tissues. So we have a lot shorter window to get to those just because of the myonecrosis and the burden of clearing that debris that takes place after anastomosis. So for those limbs, for a warm ischemia time, usually 6 hours is our general guideline cutoff, and cold ischemia time of up to 12 hours. So it does still give you some time, but I think it just highlights the importance of getting us involved early with these, that we'll get calls at times where we look back in the chart and that patient's been in the ER already for 2 or 3 hours. And we know that there are things that they have to do to get through the initial intake process if there are other injuries. But if there is any inkling that this person could be a candidate or may need a conversation about a replantation, getting us involved as early as possible to help provide direction, because it may be that we say, hey, look, for these certain reasons, this person is just not going to be a candidate. So we don't want you to spend the next 3 hours doing all of these workups and all these other things that are quite frankly not going to have a meaningful impact on what the disposition is for this patient. They're not a candidate for a replant. So get us involved early with these folks so we can help provide any guidance necessary. And I would also recommend that before any of these patients are accepted and transfer to facilities that accept these, and in the greater Charlotte area, Atrium Health and Levine are the replantation centers for our region. So our group at OrthoCarolina covers both facilities, and we are the ones that are on 24/7, 365 replant call for Atrium Health and Levine's Children's Hospital. So getting in contact with us and letting us know ahead of time. That the most challenging thing is when we get patients that have come from outside systems that are transferred down that we knew nothing about, that are being sent because they quote unquote need a replant or they're a replant candidate, only to unfortunately inform them that they're not a candidate for any number of reasons. Or if we're already in a replant, that we may not be able to get to that in a timely fashion, and they may need to be diverted to another microvascular replant center in the area, and we can help facilitate identifying the appropriate facility that could accept that patient if we don't have the bandwidth because we're already performing a replantation or other critical operation, which we may not be able to finish and get to that replantation in a timely fashion. So communication with these is key. Get us involved early. We don't like surprise replants showing up in the ER. So let us know about these early on, because usually we can help provide appropriate guidance and then also help kind of get things facilitated on the transfer side so that we're ready when they arrive. Moving on to tendon injuries, thinking about what we see most commonly, flexor tendon lacerations bring people to the ER quite frequently. And although they're not emergent injuries, they are things that can be a source of tremendous stress for the patients and can be missed not infrequently. So I would always counsel you careful neurovascular examination for these patients, because many will have an associated digital nerve and or artery injury to the digit that's involved. So we sometimes say, aha, we found that they have a tendon laceration, but the nerve injury gets missed, or delayed diagnosis occurs for those nerve injuries. I ask you to look at the just resting cascade. How do the digits rest in a normal posture? And then test each the FDS and FDP independently to each of those digits. And you can see that in the images on the right there. In the top image, holding and blocking that middle phalanx and asking the patient to flex the tip of the digit provides nice isolated testing of their FDP tendon. And then the FDS tendons, we hold down the other digits and then ask them to flex the involved digit. Partial lacerations, so those that involve less than 50% of the tendon substance, can oftentimes be treated non-operatively. These are treated with wound care and closure, counseling, hand therapy, and early range of motion without surgical repair, and close clinical follow-up with us. Lacerations of greater than 50% are almost always going to require repair. Some of that depends a bit on the location and the patient's characteristics, but the majority of those need repaired, but they don't need repaired in an emergent setting. So document the zone of injury. I think it's important if you don't have a clear sense as to each of these zones. Zone 1 is from the FDS insertion to the tip of the digit. Zone 2, we kind of call no man's land because of the challenges that happen with repairing these. That's between the A1 pulley or distal palmar crease and the FDS tendon insertion. Zone 3 is your palm. Zone 4, the carpal tunnel, and Zone 5, proximal to the carpal tunnel. So if you can document those things in the note, great. If not, just tell us where the laceration is and what you think may be lacerated. And then the biggest thing is making sure you put them in the correct splint to go home with. We see patients with flexor tendon injuries splinted straight all the time. Worst possible thing you can do for patients, because you're pulling those tendon ends further apart, makes it more challenging sometimes to then get them back underneath the pulleys to where they need to go. So I would recommend using a splint like you see in the image on the right, what we call a dorsal blocking splint, that keeps those fingers down in flexion for the whole hand. So, and that's a hard explanation to the patient. They say, wait, I just have this 1 centimeter laceration on my middle finger, but they need a dorsal blocking splint over the whole hand in a comfortable resting position of flexion until they see us. Extensor tendon injuries, similarly, there are zones that are described, and you can look through these. I think the easiest way is that the odd numbers are over the joints. So 1, 3, and 5 are the DIP, PIP, and MCP respectively. And then their corresponding even correlates are between each of those. And again, it's not necessarily critical that you document what zone of extensor tendon is lacerated, but describe where the laceration is if there's not a picture of it in the chart. So tell us where you see the laceration, how big it is, and whether or not you see the tendon or not. Similar to what we see for flexor tendons, we can move the majority of these partial lacerations of less than 50% early, and those that have greater than 50% tendon laceration are typically going to benefit from repair. Some of those can be done in the ER. Some of those we'll do on an outpatient basis, and that's where consultation can be indicated just to provide guidance as to what can or should be done. Tips for these dorsal hand lacerations: irrigate them well. You can use local anesthetic to help provide analgesia to the area and allow exploration. If you see the tendon within the wound, it's almost always the case that it's not completely lacerated. Cut tendons are going to retract. So if you can see the tendon there, it's less likely they have a complete laceration. There are some caveats there in terms of tissue structures that can hold them up. But if you see the tendon ends there very clearly within the wound, it's very unlikely that those are completely lacerated. And if they are present, try to evaluate the amount of the tendon that's lacerated. Just give us a general sense as to how much of it you think you saw was cut. Ask the patient to move the finger while you're watching the tendon to see if you see it gliding or if there's no motion across that segment. And then you can repair the skin laceration with just a couple of nylon sutures and split them in extensions. So unlike the flexor tendons that we want flexed down, the opposite is true, that we want to try to extend those digits to try to keep the tendon ends as close as possible, and then they need close outpatient follow-up with us. High pressure injection injuries you'll see, especially this time of year, from any number of different outdoor tools and throughout the year from things like paint guns, grease guns, what have you. They occur about 1 in every 600 hand traumas. Large hand centers will see a number of them per year. I'd say we probably see well over 4 per year. In our centers, it's probably closer to 10 to 20 per year. And oftentimes these get missed or delayed diagnosis as to their acuity because they appear quite benign on early presentation. Usually they start with a very small pinhole lesion early that may not be too symptomatic. Oftentimes there's no exit site, so the energy gets in and travels along the digit in the hand with no place to go. And then several hours after the initial injury, now patients are coming in with pretty profound pain, swelling, altered sensorium, and you can get infection from tissue necrosis at the site of entry. The most critical thing here is having a high index of suspicion. If the patient describes to you some mechanism that puts them at risk for this, they're cleaning the tip of a paint gun, they're using a grease gun or one of these other hydraulic fuel guns and it discharges into the hand or digit, that's someone who you need to have a high index of suspicion for. Careful physical exam, documenting the length over which they have pain, and you'll be surprised, even with some of these lesions at the tip of the digit, they're painful all the way into the palm. They need laboratory studies and a good close vital sign documentation to make sure that they don't meet SIRS criteria and don't have any signs of early infection. And then radiographs to determine whether or not you can see areas where any of that material may have been injected into the tissues in the hand and palm. That is remarkable sometimes that you see this pinhole lesion at the tip of the digit and you get an x-ray and you can see paint that tracks all the way through the palm and sometimes into the carpal canal or further. So it really can be a pretty significant injury that can be very much overlooked because of the small entry site at the time of presentation. There's differences in terms of how each of these materials interacts with our bodies. I'll tell you that the biologic or organic materials have far worse effects than inorganic materials like air or clean water. So things like grease or lead-based paint can be or oil-based paint can be very problematic because of the biologic activity that takes place. They get a lot of liquefactive necrosis, much higher rate of amputation in those series, sometimes up to 20% or more in some of the case series of those types of organic solvents, whereas inorganic materials like air or clean water typically can be monitored and have much better outcomes. So non-surgical management, usually reserved for those select patients that just have an injection of air or water only. Oftentimes they can be discharged home if their pain is well controlled and there's no concern for vascular compromise or compartment syndrome. Those patients who there is enough concern, oftentimes we don't take them directly to the OR. We may have them kept for observation, close clinical monitoring, and if there's no progression or if there's improvement, then we'll oftentimes discharge those patients home. Surgery is typically indicated for those patients that present with more florid pain, swelling, and limb ischemia findings. So those patients that come in and they already have significant soft tissue swelling, there's altered sensorium or altered vascularity to the digits, those folks are going to undergo a wide surgical debridement of the involved tissues. And it does end up being a pretty involved surgery. Many times they start with the poke hole at the tip of the finger and end up having incisions that extend over the entire length of the digit and sometimes through the carpal canal and proximal. So we can try to remove as much of the offending material as possible, debride or dilute any of the solvents that may be present, copiously irrigate, and then oftentimes we'll keep them for postoperative observation to ensure that they're clinically improving before discharging them home. So those air and water injections we see this time of year from people power washing, very different than the person who works in an industrial setting and has a grease gun or some kind of oil-based paint gun go off in their hand. Very different patients. Infections, just to touch on a couple of the most common, perinacial infections we talked a little bit about earlier. These are the things that happen when you have bacterium that get trapped between the nail plate and the perinacial fold. Most commonly, this is going to be a staph species, relatively high rate of MRSA, but we'll see sensitive staph strains as well. These are typically treated with an IND and discharge home on oral antibiotics, and this is something that can often be done in an ER setting, so they don't necessarily have to wait to come to the office to have this done. This can be done with removal of only a small segment or wedge of the nail plate on the ipsilateral side where the infection is taking place, or if it looks like it's involving more of the eponychium or the perinacial fold on both sides, I have a very low threshold to remove the entirety of the nail plate to allow for decompression of all of those tissue folds around the nail complex. We'll usually discharge them home on oral antibiotics, making sure that they have appropriate MRSA coverage. I oftentimes will recommend to them a warm soak for the first 3 days after surgery or discharge with a 1-to-1 mixture of peroxide and distilled water, just to try to help wick out any of that additional material. And they should follow up with us in clinic in 5 to 7 days after discharge, but it's rare that these folks need to go to the OR. Most of the time, this can be done at the bedside in the ER with close outpatient follow-up with us. Felons, similar type of problem in the distal aspect of the digit, but this time we're worried about the pulp rather than the skin folds around the nail complex. Patients are going to present with a very tense, painful pulp of that digit. And those similarly are very amenable to a bedside incision and drainage and discharge on oral antibiotics. I think the most critical part where people can fail with this is they don't make a big enough incision or they don't take enough tissue. They're worried they're going to injure something. But again, in that very distal aspect of the digit, you're beyond the flexor tendons, you're beyond any of the major peripheral nerves. So they need a real, 1 centimeter at least incision there on the mid-axial part of the digit just to get enough space to adequately decompress the tissue there. And just making a little stab incision is not going to do it. You really need to use some sort of debridement device, either a hemostat, some sort of dissecting scissors, or something to help open up all of those septations in the fatty tissue in the palm to make sure you break up all the areas where that pus can hide. Otherwise, we'll see people that had a decompression at bedside in the ER, but they really just had a small little stab incision. We get 1 dot of pus out of there, but it really hasn't been an adequate decompression of the pulp. So I go through that same process, decompress the pulp. I'm not always big on putting a wick of new gauze or an impregnated iodoform gauze into that area. Certainly very reasonable to do so if you feel comfortable, but at a minimum, it needs an adequate decompression, not just with a small poke incision, but a true incision along that mid-axial part of the digit and a really robust decompression of the pulp. And then those folks can come see us on an outpatient basis about 5 to 7 days after their initial consult. Flexor tenosynovitis, this is something that we get a lot of transfer requests for, and it's something that's a big buzzword in terms of anything that's an infection people think is flexor tenosynovitis, but it's a fairly specific problem. This is an infection that's confined to the flexor tendon sheath, oftentimes from either some sort of penetrating trauma to the tendon sheath or direct spread from something like a felon or a septic joint that hasn't been treated. Again, Staph aureus is going to be the most common, and the signs that we look out for and the things that we like to hear in a consultation request are documented are these canaval signs. So fusiform swelling of the digit, a resting fixed flexion posture, pain with passive stretch of the digit, and then tenderness along the flexor tendon sheath. So you should be able to palpate along that entire tendon sheath, oftentimes even into the palm proximal to the area where they may have erythema. Those are all signs that we would want to hear about and know in consultation. If they have 3 out of 4, these are certainly 4 out of 4, that person is likely going to benefit from operative debridement. Sometimes in early presentation, so the patient comes in and they've had the prodrome of symptoms, they may have 1, perhaps 2 canaval signs. That's not always someone that we take directly to the operating room. For some of those patients, they can be treated with IV antibiotics, repeat serial examinations, and close outpatient follow-up if they demonstrate improvement with antibiotics alone. I feel like those folks pretty well separate and dichotomize to either those that do great with IV antibiotics alone and go home, or people who really have no significant improvement in their symptom progression or worsen and ultimately require an operative debridement. But this is a group of folks we want to hear about, but not everything that looks infectious in the finger is a flexor tenosynovitis. So I think it's important to have a very close examination and be able to document those canaval signs to help with the decision making. And then fight bites, these are things that we see come in delayed fashion all the time. We get people that get into some sort of disagreement. They strike someone with a closed fist. The tooth punctures the tissue, but the challenge is, if you look in figure 2 on the bottom right, the area where the tooth initially enters is in a position where those tissue planes are all spread out at different layers. So the area where the skin, the tendon complex, and then the joint capsule and bone are injured are at different layers. And what happens is the bacteria in our mouth gets trapped inside those tissue layers, and now it can proliferate and doesn't drain. So the wounds may appear benign initially, but you'll find that there's oftentimes more florid pain, more significant swelling than what you may appreciate, because that bacterial burden has been replicating and is now sealed below the skin surface. On early presentation, similar to Flexor-Tino patients, many of them can get oral antibiotics in close observation. In the late stage, they come in, it's been 24 hours or more. Those folks typically require a surgical debridement. So this is a patient that we need to hear about, because they typically need to have surgery. And then finally, animal bites. I always tell folks that I lose more hours of my life to cats than almost anything else. Cat bites, because of Pasteurella burden, are far more common in terms of resulting in a local skin or soft tissue infection or even an abscess formation than dog bites. Dogs, we usually see more blunt soft tissue trauma or fractures, and humans are somewhere in between the two. We saw what fight bites can do. The mouth of a human is quite dirty, high rates of fracture, and high rates of infection. With early presentation without an abscess, many of these folks can do well with initial IV antibiotic management. Unison is the preferred agent because it has appropriate coverage for Pasteurella, and then if they respond well, discharge home on oral Augmentin. Late presentation with abscess formation or with progressive findings, usually they're going to need surgical debridement and then admission for IV antibiotics before discharge home. So take-home points, I know there's a ton to cover. The biggest thing is that you have to really have a critical examination of these patients, know their neurovascular exam and tendon function, and not be led astray by the size of the wounds, that even small wounds in the hand and wrist can pose really big problems. One thing that we hear a lot of source of stress about is what we do about open fractures or gunshots. And in the hand and wrist, not all of these are operative emergencies. So certainly things that we can hear about and be consulted about, but many of them do not need to stay and go to the operating room. There are definitely some injuries that should reliably trigger urgent involvement on our part: unstable open fractures, ischemic or amputated digits, the high pressure injection injuries, and then the surgical infections. And good early management and clear disposition are the things that are going to be most helpful. So over communicate with us. We're happy to hear about them, happy to help triage, but I think you'll be surprised at the number of things that now we can manage on an outpatient basis rather than keeping these folks in the house. So with that, I'd open it up to any questions that you have. I have my personal cell phone on here, email. Feel free to shoot me a text, email anytime if you have questions about logistics, if you have patients you're trying to figure out what to do with, always available. So feel free to shoot me any questions, concerns you have at any time, and definitely want to make sure I can get to any questions that you all have about that information.
Thank you so much, Dr. Grier. If there are any questions from the audience, I have one I would like to ask. I feel like when a provider has with a patient with what they perceive to be a severe hand injury is told that the patient can be sent home with outpatient follow-up, which you touched on earlier, they might be uncomfortable discharging that patient. What do you say to that, or what can they do or document to make that process smoother?
I think the biggest part of it is understanding, on both sides, so that we can make sure that we understand the reasoning, because there may be something that we're missing, that there is a reason that patient needs to stay that we just don't quite understand. But if there is, a clear reason that we say, hey, this person can be managed outpatient, they need a surgery, but it's not going to be done in-house. I think it's just making sure that, that practitioner can then document that conversation. If we're making that recommendation, we should feel comfortable having you put that on the chart and say, hey, we spoke to Dr. Grier or whomever and explain the clinical scenario as it presents, and this was the recommendation that they follow up. And I think we do a pretty good job on our side of really making sure we get those patients in to see us quickly. We have a mechanism in place that allows for, next day scheduling for any of those folks, or even same day if it's early enough, so we can make sure that we get them in. But I know it is a common source of, frustration on both ends, that there's this sort of impasse of, I think you need to see this person, and us saying we don't think we need to see him. And sometimes it's a resource situation that is, hey, we really want you to see this person, but we're in the OR across town, and this is something that can definitely go home. So really just kind of taking our word for it, making sure that if there's not something that we've made clear, that we can help better explain why we think that person person can go home and doesn't need to be managed inpatient, and knowing that that then becomes our patient that we need to manage on the outpatient basis.
Right. There's a question in the chat from the pre-hospital side of things. What are your recommendations for transporting amputated extremities? ICE is not always available.
So ice is really the best option. That we want to try to make sure that it should not be submerged in any sort of fluid. So it used to be that people would put these in saline or ringers or other things. The best thing is if you can take the amputated part, it can be gently wrapped in like a moistened gauze, but not something that is wet or in water. And then if possible, ice is critical. I mean, someone can run out and get ice, or there's ice on the floor somewhere that, if it's in the field and you're coming from the field to the hospital, then just doing so as expeditiously as possible. If you are at an outside facility where a transfer is going to take place from facility to facility, trying to minimize the time that that part is exposed for evaluation at the initial facility so that we save as much cold ischemia time as we can for the accepting facility. But if there's truly not ice available in the field, then getting them to a center where that can be applied to the amputated part as quickly as possible, and not doing things like submerging them in water or other solutions that can be very deleterious to the tissues.
Great, thank you. In general, trauma centers tend to accept almost every trauma transfer, but you mentioned needing some more information sometimes when it comes to things like hand amputations. Can you go further into that?
Yeah, a lot of it is, they'll call, and oftentimes we don't get consulted early, that they call in the, either general surgery, trauma, vascular, or someone else is called about what may be a limb injury, that may be something that we need to be involved in. That is very helpful to include us on those consultation requests so that we can provide some guidance too, because there are a lot of folks who are accepted and transfer by other service lines. They arrive and then we're asked or sort of told we need to see them in consultation, when in fact they really don't need an ER consultation for the injury they have, or we would have not necessarily accepted that patient and transfer. For example, a lot of replantation candidates, like, hey, this person's here, they need a replant. But had we been called hours ago, we would have said, this person is just quite frankly not a candidate for a replant, or we just don't have bandwidth if we're already doing one or some other emerging case that is going to supersede what was transferred in. Getting us involved early can help to save some of those unnecessary transfers, which had a ton of time and cost to the health system and result in delays in care for the patient, having unnecessary transport for them hours from their home, and cost for them to go through all of these elements of the system that we could have helped triage early on. So we'll have a lot of folks that come in and it's for an isolated, amputation of a digit or other part. That really needs to go through the hand and upper extremity consultant. With all due respect, the general surgery trauma folks or vascular surgery folks usually are not going to do anything with that person. Caveat, sometimes on the vascular side, we need help if it's proximal, it's up in the axillary or higher, brachial sometimes. But for the distal extremity injuries that are things that fall into our realm or would be considerations for replantation, we should be involved early so we can help provide guidance as to whether or not that person would benefit for transfer and how timely that needs to be. Because sometimes they're ground transported when it's like that person is already in a critical window. They may need to come by air if air is safe and available.
Thank you for clarifying on that. Any other questions from the audience? All right. I'm already getting messages from folks saying what a wonderful presentation that was and very informative. So we greatly appreciate your talk, Dr. Grier.
It's my pleasure. I really appreciate the invitation. Thanks for allowing me to spend some time going over some of these things, and truly take down my number, cell phone, anything I can ever do to help anybody with these consultations or systems issues. Happy to help. Thanks to everybody for your time. Hope you have a great rest of the day.
Thank you.